welcome everyone this evening to the second session in our End of Life in Primary Care webinar series. Thank you for taking the time to join us this evening, and I trust that you will get a lot out of the session. I would like to acknowledge that we're meeting and hosting this event on Ngunnawal country. Let me progress that slide. My apologies. There we go. To acknowledge that we're meeting on Ngunnawal country and pay my respects to the Ngunnawal people as the traditional custodians of this land we're meeting on, and acknowledge their elders past, present and emerging. And I also extend our respects to any Aboriginal and Torres Strait Islander people attending the sessions today. So this is number 2 session in our webinar for End of Life in Primary Care. So today we are focusing with, last week we had End of Life Law for Clinicians in ACT. And if you did not get a chance to attend that session, it will be recorded and uploaded onto the CHN YouTube channel for you to watch. We had really great feedback regarding that session. So tonight we are lucky enough to continue our learning with end-of-life discussions, advanced care planning resources and documentation in ACT. We are very lucky to be joined by both Janine Rath and Dr Raymond Liu. Janine currently is the Advanced Care Planning Manager in ACT, working for Canberra Health Services. And not in the past used to be a practice manager at East Canberra General Practice, and prior to that, and she hasn't asked me to include this, but I think it's really important, she spent many years in community nursing, so she has a very well-rounded understanding of a patient's journey as they approach end of life. So thank you, Janine, and I welcome you for the session tonight. Thank you.
Thanks, Ros, and welcome to everybody. I feel a bit awkward because I'm used to talking to people and getting some feedback. So I'm happy for you to put your hand up or type answers in the chat if I ask a question. We'll see how that goes. I'm happy to take questions throughout the presentation, or if you'd rather just wait to the end. I'll start sharing my screen and we'll see how that goes. Are we there?
Yes, we are.
Hooray. That took a little while to do before. So I thank Ros for her welcome to country tonight. In the chat, or raise your hand and Ros will let you know, if you're planning an event, what are some of the things that you would think of for event planning? What are some of the considerations that you would think of for an event? Good. Food. Any event, I didn't name it. Maybe a location. Date. Attendees. These are great answers. So if you're planning the event, but music, righto, that could be controversial, Ross. If I was to tell you that you could only have country music and you could only have 6 attendees and it was going to be on this date on my property out in the country, how would you feel? You can write your answer there as like, what would you think about me dictating what was going to happen at your event? Oh, someone wants rock music. Someone would feel really cranky. Oh, 2 people would feel really cranky. So what have I dismissed on your behalf? What have I removed from you on your behalf? Yeah, you'd feel robbed. That's a really strong word. Thanks, Barb. What have I removed from you? Choice. Yeah, that's yours. It's not mine. It's yours. So I keep swapping slides. I've taken away your choice. So what is advanced care planning? Advanced care planning is choice, and it's your choice. And if I go to the very long-winded advanced care planning definition, it's got lots of words in here. It's about planning for your future. It's opportunity to think and discuss your record about what matters most to you. The simple explanation of that is this is an opportunity for you to think about the choices that you want, to write them down and share them so that your choices are valued and respected. So the key components of advanced care planning are to designate a substitute decision maker, and we'll talk about the documents that do each of these roles as we roll on through. To have discussions about your values, wishes and beliefs. To write a written plan, share the plan, and the plan is available and reviewed. And I want to circle back to that reviewed later on. Most importantly, it's voluntary. We have unfortunately seen some situations where mum and or dad have sort of been shuffled into our office going, they need to do this. Mum and dad don't often want to do this. So we do ensure that the people who want to do it are there because they want to do it. So why do you reckon we do advanced care planning? Get your little fingers typing, because it's a pretty scary thing. So why would we ask you to do it? Well, people think it's scary. Hopefully by the end of this you won't find it as frightening. To be clear about your wants, yeah, to have our choice. To assist family and carers, to make your choices known. All really good reasons. Excuse my humour, but the bottom line for doing this is because it doesn't matter what century we were born in, the statistics are the same, that we all are going to die. And advanced care planning, along with palliative care, comes with a pretty bad rap because they initiated with the last few days or weeks of life. And then we thought, oh, that works really well. So we'll do it for the people with life-limiting diseases. And then we thought that works very well. We'll do it for people who've had 70 plus birthdays because they're a bit closer to death. But we've missed a whole range of people who are well and probably don't think they need it because it's a bit scary. We try to frame advanced care planning as this is your chance to tell us what living well looks like and how medical people can support that. Here's why we do it. It allows people to appoint, and in essence, this is just saying it allows people choice and it allows people to share their choice. And you know, our code of conduct as doctors, nurses, physiotherapists, occupational therapists say that we have to. Oh, I can't see slides very well. Why is that something I'm doing? Or is it?
I can see them okay from my end.
Okay. All right. Let us know, Jan, as we go through if it gets any better, and we'll see what we can do. So in your code of conduct, it says that we actually have to facilitate advanced care planning. And in the health service that I work in, social workers are associated with this a lot, but it doesn't mention them. But they actually have their code of ethics that say they have to assist with self-determination and autonomy, which is about people having choice. The slides are very small on my screen. Are they big on your screen, Roz?
Yes, I can see them. Canal, any suggestions to help?
I've just made some changes. Please continue. It should be fine now.
Okay. Yeah. All right. Need to share slides as you can see me, not the slides. Okay. So I'm going to stop sharing and start sharing again. Should I, Canal?
Janine, it's fine. I've made some changes, so I think so it's back to normal for your slides.
So just keep going?
Yeah, keep going.
Okay. All right. So I like this slide because it explains advanced care planning well. They say someday we will die, Snoopy. And they say that's true, but on other days we will not die. And we want to make advanced care planning about the days that you are not dead, because they're the days that we want to know about, because that's how we decide your choice. And that's called living well. And the way that we approach this in a positive manner with our consumers is tell us what living well looks like for you today. And if you had a critical event today, what medical support would you accept? Oh, I'm tapping my book, not my computer, sorry. Who needs advanced care planning? Some answers in the box. Type someone or a demographic that you think would need advanced care or would benefit from advanced care planning. Oh, Melanie, you're on the ball. Everyone. Well, there is a subset that's not there, but that's, oh, everyone, good. We're preaching to the converted. The choir's singing already. That's great. So I've got a little 18 plus is still a good one. Everyone, we're on the same ball. So I've got some slides of some people. Does an elderly man who is well need advanced care planning? That's a population that we focus on naturally. What about a mum with breast cancer? We also focus on them naturally because they've got a life-limiting disease. Someone living with a disability, we've started to get into that space. There's still a few questions that we have got unanswered around that, but we're making inways. What about a teenage boy in his late teenagers? People would often go, oh, I don't know why, but I'm the bad cop. When my son, who's now 25, turned 18, this was his birthday present, his advanced care planning and his enduring power of attorney. And he said to me, Mum, you'll know what to do. You're a nurse. And I said, I won't know what to do for you. So I want you to tell me, even though it might make me sad, what would work best for you, because I don't want to live guilty and I don't want you to live angry. And he went away. 3 days later, he came back with his documents. Multicultural is another space that we're working in that gets bigger all the time. There are some cultures where this is not an acceptable subject, but how do we talk about that in a health institution that requires these documents to provide care? Tricky space, but again, we're trying to work out how to do that respectfully. And young families. So when do you do advanced care planning? Typing fingers again. When do you think would be an opportunity? What would be a trigger point? When would you think to have this discussion? Oh, Estella, you must have heard me speak before. When your will is best. When you write a will, that's a good prompt. Health assessment. I think, if I'm correct, Melanie is a GP. Is that right? Yes. Yeah, so they're all good times. So here's some prompts that I have put together, particularly important if a person is older, has a chronic illness, has multiple diseases, has a life-limiting disease, has early cognitive impairment. So early cognitive impairment is not a deterrent to do it. It's quite an alarm bell to get it done before the impairment increases. Other opportunities to discuss advanced care planning, and I sort of approach this from my GP practice nursing days. If a person requests to have a discussion, that can be quite scary if you're not used to this space. Health assessments, which have been mentioned by Mel, but everyone should consider advanced care planning regardless of your age or health. Ideally, you should start planning when you're healthy before it's actually a problem. And if we could get more done in that space, we'd be in a better place. Doing them when people are unwell, often they're stressed, good to do it, and often it's a trigger. The other trigger is if the spouse gets unwell and they're asked to do one, the remaining spouse will want to do something as well. I say basically any time that someone's in a medical environment is a good time to talk about advanced care planning because it's for everyone, not just the old and the unwell. So it's all wonderful and it's all good and we should do it for everyone at any time. Why don't we do it and why? So what do you think the percentage of the population is in Canberra Health Services that have these? We can only measure this when people have passed away. What do you think the percentage of deceased people at Canberra Health Services is that have documents, advanced care planning documents on their file? Type a number. 5, 25, anyone else? 20, 10. So the national average is 14%. So no one no state does well. but for the last couple of months, ACT Canberra Health Services have been bumping around 20 to 22%. So we're a little bit chuffed about that. I can't claim any glory for that. I think that it's just people becoming more aware and having more of these conversations. So thank you for everyone out there. So why don't we do it? What are some of the things that stop people from doing these important conversations? Any ideas? Time. Yeah, big one. People say I'm not that sick. That's correct. No one asked. It's scary. All of those things. And the no one asked is really interesting, because you would think as health professionals we're pretty comfortable talking about this, but data shows and research shows that not all health professionals are comfortable in this space. So Advanced Care Planning Australia, one of their big projects for next year is to run a public health campaign like breast screening, like cervical screening, like bowel screening. So many years ago we didn't talk about those things. They were hush words. We were all on the same page that advanced care planning should be in that basket of being comfortable to talk about. Cultural barrier is a good one as well. We've got a lady called Chin who works in the multicultural space, and she does a fantastic job getting this message into a number. I think she's worked really strongly with 5 different communities: Indian, African, Chinese. I can't think of the other 2, but she's doing a fabulous job. And we don't actually measure her success by the number of documents we have. She just has conversation after conversation after conversation. Chin is there. You're welcome, Chin. You're my little champion. So here are some barriers in no particular order. Fear, both by the consumer and the medical person. Thoughts of it not needed yet, which has already been mentioned. Lack of understanding and the knowledge about advanced care planning, and that's both by healthcare professionals and by the consumer, that they don't know what it is, or that it's even available, or even that it's a thing. Lack of time and space is huge. Cultural diversity and health literacy. We live in such a multicultural country that the level of health literacy is very vast. So I work with HCCA a lot, and they assist me with a lot of easy read. They work in that space with the communities, and unclear about who should actually ask the first question. Do I ask my GP, or does my GP ask me, or who asks me? So who should be involved in this discussion? This is not a be-all and end-all list, but who do you guys think should be involved in the discussion about advanced care planning? The patient and the people who support it. Family, yep. Here's our non-extensive list. The person who is considering their future and their care. The substitute decision makers. The close family and friends. The carers. And any health professionals that are involved. That's just a basic list that keeps it fairly simple. So we figured out why it's good, why we don't do it, who should do it, when we should do it. But in ACT, how do we do it? Does anyone had any experience with doing ACT advanced care planning? So when I was in GP land and in community health, I would always start my discussions with something like this. Three general questions. If you couldn't talk for yourself and you're really crook, have you chosen someone? Oh, it's on Health Pathways, it is, Mel, yeah. How do you find the Health Pathways? Can you just type a note? Is the Health Pathways instructions good for this space? I think so, good. Simple questions so that don't sound too confronting, we've found is, if you were ever in a space that you couldn't talk for yourself, is there someone who could speak on behalf? And then that flows on to, well, have you appointed them legally, because now next of kin is not a thing. And that leads you to, have you done an enduring power of attorney? And then would they know what you want? So really simple sort of non-confronting questions that don't even speak of death. It's just talking about a moment where you might not be able to communicate what healthcare you would want in a health event. And in GP land, I generally generalize it. We often talk to all patients about this. Would you mind if I gave you a bit more information about it, particularly in our health assessments, both at the 45 and 49 and the 75 plus ones? These, like I said, it's coming from my GP practice time. We include, and these are downloadable, really good resources. Fill in the blanks, finish the sentences, gives people just opportunity to prompt them, good prompts about what they think would be important to them. Some important things to keep in mind: timing. People in distress are not always the best people to do these. Voluntary, I've spoken about that. We'll come to the legal documents. The question of capacity is huge, and I'm not the person who decides if a person has the capacity, although I have a really low threshold of completing enduring powers of attorney if I don't think a person has the ability at the moment. And location. We find it difficult in hospitals where there's shared rooms to have these sensitive conversations. So we try to do them as outpatients rather than inpatients. There's some really good resources about questions and helping people. Palliative Care Australia have a whole page of discussion starters and prompts and little cards, and Advanced Care Planning have some resources about how to have these conversations. Here we'll just quickly touch on ACT Advanced Care Planning documents. So this is the cobweb of Advanced Care Planning documents across Australia. You can see it's complicated. Nothing is standard. Every state has different documents that have different legal components to it and require different input. Forget that for the moment. In ACT, we use 3 documents. One is the enduring power of attorney, which appoints your legal decision maker. The beauty of the ACT one is that it incorporates all the functions. It incorporates financial and property, personal care and healthcare, and medical research all in one document. In other states and territories, you need multiple documents to authorise those functions. Of note is the other, to note that if you're asking a health question, that the person you're asking the health question to has been appointed the authority to make health decisions on this document. So just because they've got an enduring power of attorney, don't assume they've got the authority and function of healthcare. There's on page 3 is the function list. Just check that they've got the authority to make health decisions. Legal statutory document. The next one is statement of choices, which is not a legal document. In most other states and territories, they call it an advanced care plan. ACT just like to be a little bit different. This is where people put their values and preferences and healthcare wishes. I like this document a lot because it's about you. And in most states, it's not a legal document. It's in that it's not statutory legal, but it has been used in civil and criminal courts to charge medical people with battery and assault because they've not followed it. So while it's not a statutory document, it's been used for those purposes. I don't know how big your screen is, but this page on the left is, we tell it storytelling about yourself. And when you finish that, you feel like you've been a bit like on Roger Kimpson's This Is Your Life, because you've told us what a good day is, how your health conditions affect you, and all the important things in your life. And people often go, well, what am I telling you all this? You know, this has got nothing to do with my health care. Because on the next page, the first question is, if my heart stops, what do I want you to do? And one of the answers is, I want you to give me CPR if you think I can get back to my previously described quality of life, noting that the person who is probably reading this document has never met you before, so has no idea what your good quality of life is. That's why we get you to fill in the left-hand side of the page so that the doctor can see, use it as a measuring stick of, okay, this is what their quality of life was before. What do I think the chances are of them getting back to that? The second question on that page is about life-prolonging treatments. That's about things like, we say it's not an endless list, but we do point out breathing tubes, feeding tubes, blood products, surgery, renal dialysis. People get really worried at this point that if they don't tick all the boxes and list all the treatment, that something will be done to them that they don't want done. That's a goals of care discussion that Raymond will probably touch on in his next presentation. This is an overarching document. There are many documents around that have far more details. You know, if I take breathing for an example, if I need assistance in breathing, do I only want oxygen in the mask, or do I want pressurized oxygen with a CPAP machine, or do I actually want to be ventilated and have a tracheostomy? Some people want that nuts and bolts. We don't often go to that depth because often that is a goals of care discussion on a hospital admission, and that's a different discussion all round. There's a box for when I near the end of my life, what's important to me, place of death, people, atmosphere. I haven't got a picture of the back page, but on the back page is a section that's got a really amazing word, and it's review. We like these to be reviewed every birthday and in between for a health bump. And I'll tell you, I apologise for people who've heard this presentation before, but it would have to be my favourite story about being a community nurse. To have access to the community nursing service when I worked in rural New South Wales, you had to have an advanced care plan. And I met this beautiful 70-year-old man who was a farmer, not a thing wrong with him, fencing, chopping wood, shearing sheep, fighting fires. And he said to me, Janine, I don't even have time. Just tell them I want everything because I'm going to live forever. So we did that shortly after he got his diagnosis of a life-limiting lung disorder and bumped in and out of hospital, tried medical treatments for the next 6 years until he passed away. And each time he bumped in and out of hospital, it wasn't if you go back, it would when you go back, would you do the same treatment again? Because that looked like it was pretty rough on you. And if he started a treatment and the burden was greater than the benefit, we would talk about it and we would adjust what a good day looked like and what living well meant for him and what medical treatment he would accept. The one we did shortly before he passed away, his good day had gone from shearing sheep, building fences, chopping wood, to if I can sit in my lounge chair with my oxygen on and listen to my ABC radio, I'm having a good day. But if that was his worst day imaginable 6 years before, but because we had reviewed this through this, it went with him and he was able to tell his health story at all times and always have the opportunity to be heard. The third document we use is a legal document called a health direction about withdrawing or withholding a really specific treatment. The advanced care planning team doesn't do a lot of these for a couple of reasons. If we do a good statement of choices, we don't often need this. But if someone wants to do one about a particular treatment, we do ask them to go to the medical treating doctor who's providing that treatment to have that discussion so it can be an informed decision. This is the old version. Advanced Care Planning Australia has revised it. This is for someone with insufficient decision-making capacity. So the grey area here is if the person has appointed an attorney while they have capacity, but haven't done a statement of choices, then the attorney can do one of these on behalf of the person after they lose their decision-making capacity. If the person has never had capacity, therefore can't appoint attorney and has a guardian, the guardian, by omission of the Guardianship Act, cannot do one of these because life-ending treatment is not included in their guardianship orders. We are on having a meeting with the tribunal to see what the process would be about including that option in guardianship orders, because we feel that particularly we have aging parents who've been caring for people living with a disability for all of their life, and they've been their guardian because they've been born without decision-making capacity and now do not have the ability to write an end-of-life document for the person that they've been caring for all their life. We'll watch this space and see how that goes. So end-of-life decisions should not be made at the end of life. Here's some more resources. That number in the big red is our team. We do community sessions where we meet one-on-one with community members at various locations around Canberra to support them, either understanding and or completing these documents. And as I said, there's lots more I could yap on about, but our aim is to get your ducks in a row. And there you are. I did it in under half an hour, Roz.
Thanks so much, Janine. Thank you. Any questions for Janine? And it's interesting, even the colour of the ducks might vary from one person to the next, right? So we need to make sure we have the right coloured ducks that we would want and in the direction that we want them to be facing. Thank you for your comments and participation and responding to Janine. Is there any questions or things that you would like clarified, please?
So, sorry, I just say that in ACT, it's one of the only jurisdictions that you do not need input from a legal practitioner to do an enduring power of attorney. The only requirement is that, of course, the person be over 18 and have capacity, and that one of the witnesses has to be from an authorised list to be able to sign a statutory deck.
Great, thank you. Thanks for that. Janine, if we do succeed in encouraging our patients to complete these documents, what happens to them next?
As there's no central repository in ACT or Australia, the best thing that we offer, advice we offer the people that we do documents with, is they keep the original themselves, they give a copy to their decision makers, they give a copy to their GP, and they place a copy on DHR, which is My Digital Health Record, which is ACT Public Health only. If they're going to travel interstate, we ask them if they want you to put on My Health Record, which is national. So My DHR only gives access to ACT Public Health. It doesn't give access to GPs, it doesn't give access to ambulance, it doesn't give access to private hospitals or private health, nor does it give access to any legal practitioner. So if you want, that's why we encourage GP. And if you want the ambulance to see, we are working and we are nearly there to give ambulance access. If you put a copy of it on the side of your fridge or on top of your fridge, the ambulance are happy to take a quick glance there if the incident happens at home.
How do they get assistance for those documents to be put on DHR and My Health Records? How does it get there?
So in the little booklet that we provide, there is an email address if you happen to have the ability to scan and email it to our medical records health information system, or you can email it to our team or post it to our team, and we'll put it on for you. My health record we can't access, but some GPs have the software to do that, or there is a YouTube for the consumer that shows the consumer how to do that themselves.
Okay. Lovely, thank you. And please email us questions post the webinar if there's things that you think of when you get back out into your workplace. Thanks, Janine. Thanks very much. Thank you. So next I would like to introduce Dr. Raymond Liu. Dr. Raymond is currently a GP and also an ANU academic with very broad research interest, including palliative care. I met Raymond quite a few years ago now, before he was a GP, when he was first engaged with palliative care in a research capacity. And I can say that I've watched Raymond combine both his interests in research, palliative care, and now working as a GP in general practice. Thank you so much, Raymond, for joining us tonight. Thank you.
All right. Thank you, Ross, for the introductions, and it's my great pleasure to give a chat about serious illness, care goals forums, and I'm going to talk a little bit about my reflections on goals of care discussions. Now, before I start, I just want to acknowledge the Ngunnawal people as the traditional custodians of the land we are meeting today. And we're meeting on and recognize any other people or families with connections to the lands of the ACT and the region. I want to start off with a story. Yeah, so this is a story about one of my patients I saw in 2023. In 2023, there was a patient called AD. This is a lovely 91-year-old gentleman. He's an Italian migrant, has an extensive history of chronic illnesses. Particularly, he has congestive cardiac failure, and functional decline, and also Parkinson's disease. Now, I was fortunate to be his GP because one of his regular GP was on leave and took a few months off and traveling overseas. So he came and saw me, and interestingly also that his primary carer, JD, is also my patient. Now, when I saw him in August 2023, and I noticed that his conditions were deteriorating quite gradually, and in fact, I saw him almost on a weekly basis because of his worsening shortness of breath, and then swelling ankles, and on top of that, he's quite deconditioned, and he's just losing the appetite to eat, and he's gradually fading away, losing his weight, and worse is was he has multiple presentations to the emergency department for the exacerbations of the CCF. And my role at the time was, seeing him every week or every fortnight, just assess his fluid status, listen to his lung, adjust the fluids in mind, have a sort of like a plan moving forward, and try to make him as comfortable as possibly can. I had this opportunity to get to know these patients. And in fact, from August till December, when he saw me, and we start chatting away about his life. And we talk about the family, talk about his as an Italian migrants, he migrated to Australia in the 60s. And he started telling me a lot of story about his life. One of the things he told me about was his marriage. He told me, I remembered, after seeing him for about 3 months, around about November, and he told me the story about how he felt sad and a lot of guilt about his first marriage. When he came to Australia, he married very soon and to an Australian wife, and there was a lot of expectation, and there's a lot of cultural differences. At the time, the marriage fell apart. And what made him so sad about this was that he could not see his children for a total of more than 50 years. And he said that the last time he saw his children, the children hated him. And he bursted into tears. And I asked him, I said, look, is there anything I can do? I know that this sounds like very important to you. And he said to me, there are a few things that he likes to have to do is I really want to reconnect my son and also my daughter. I haven't seen them for 50 years. I don't know what they're doing. I know that they're in Canberra. And that aside, I want to eat spaghettis because I love my wife's spaghetti bolognese. And he said, I don't want to die in the hospital. So no matter what, I just want to die at home, and do not send me to the hospital. And he loved his Italian food, and he told me that his wife make amazing food, particularly spaghetti bolognese. And every time that he saw me, he would tell me food that he ate, but he can only eat a little because he loses all his appetite. The other thing that I find interesting, I asked him, what are the things that you do during your free time? And he said that, look, I like vintage car. I repair them. I bought them. I fix them up, and I like to show them because there's a vintage car exhibitions, and the people who collect vintage car will know this guy very well because I had an opportunity because I did a home visit, and I tried to have a good understanding about his life, and trying to figure out what makes him happy. So he showed me his cars. Now, I remember there was the time when I saw him and he was deteriorated quite rapidly. So I did a home visit. And at the time when I saw him, and he looked so tired, and his saturations are only 85%. And he was sitting in the dining room and not really engaged with me. And I said that, well, look, you told me that you have really good connections of the old car. Would you like to show me? And then he would just suddenly woke up and as if he has a burst of energy. And then he said, why don't I show you? So he took me to his garage, and these are the pictures he showed me. It was amazing. And he bought this car. He has been repairing motorcycles, all these amazing cars. And he's a carpenter. He replaced all the woods and he fixed them up. And it was very, very proud of them. And in December, I noticed his deteriorations. He couldn't eat, and he has this incredible shortness of breath, and his lips are blue. When I saw him, his hands are blue and very cold. And I completed the advanced care planning at the time, and I just after the Christmas, I refer him to the home-based palliative care. And we commenced a palliative care pathway, including de-prescribing, with the main focus on making him as comfortably as possible. So I do a home visits on a regular basis, and I was in regular communications with the home-based palliative care team. And now, remember I told you that one of the last thing that he really wanted to do was reconnect to his son. So for some miracles, I happened to have some contact and was able to reach out to the son. And I explained to the son about the situations. And unfortunately, he wasn't interested in reconnecting with his father, but he discussed the situation with the sister. But he did talk to AD's current wife. And AD unfortunately deteriorated rapidly, but thanks to the palliative care team, the home-based palliative team, he spent his final days at the Clare Holland House, despite the fact he wanted to die at home, but he said that he's happy to die at the hospice. And 4 days after he died peacefully on the 28th of January. Now, this is not the end of the story. And what happened was his son did not come to the funeral, but his daughter from the first marriage came. And right after the funeral, the daughter approached AD's second wife, the carer, and said that she said to her, she said that I'm glad to know that AD was happy. To this day, I'm still not sure why the son didn't want to meet his father, but he said that from what I heard from the wife, he's still not very happy. But turns out the son also had a terminal cancer, and he died, I think 2 weeks after. And his wife, JD, which is the AD's wife, was very grateful to the care AD's received. Now, I want to bring these stories because this story allow me to reflect a lot about goals of care discussions. And first of all, I found engaging AD is very difficult because of his cultural background. He has a very stubborn, very stoic personality. Every time I ask him how are you doing, he said, "Oh, I'm fine, I'm okay." And despite the fact you listen to the line, it's by basil crackers, it foods everywhere, and he's still plodding along, back to his house, looking at his, lovely vintage car. He doesn't want to tell people that he's suffering. Until, I was able to earn the trust of him, and he told me about his guilt. And that was very surprising, even to his wife. She said to me he never told anyone about it. I found that any goals of care discussions requires a lot of patience and very gentle, it's very empathetic, and have to have a meaningful discussions, but at the same time very clear to ask them, what exactly are we achieving now? What do we want? And is there anything that I can help you to achieve those goals? And often this is not a one-off discussions. And to general practice, this is going to be very difficult. It's an iterative process because you have to give them time to think through what they want. And then you have to invite them back and discuss that with them as well as the family and the caregivers. Now, in situations such as cancer patients, where the prognosis is a lot more clearer, in situations like AD, it's a lot harder because, yes, congestive heart failure, the prognosis is unclear. But then again, there are some studies also found that very small fractions of the patients with heart failure will have an end-of-life discussions because clinicians wasn't able to recognize the deteriorations. And unfortunately, less than half of these people have advanced care directive being completed. And I think this is very important for us to recognize, dying patients, but also patients with chronic illnesses. As what Janine said, it's never too late to start these conversations and start completing advanced care planning. Another story of mine just came in last week. One of my patients, I did a skin excisions on an 89-year-old or 84-year-old lady. She's a lovely, lovely Australian lady. And I cut out a skin cancers of the lower leg, and we had a lot of chat. One of the thing about skin cancer excisions is that often you'll be surprised how much conversations you can have during the time when you excise the lesions, because they have no choice except to have a conversations with you. So we chat along, and she talked about her life, and towards the end, I finished excisions and I spoke to the daughter, which is also my patient. I said, look, I think it's time, to discuss with her about, to have goals of care, statement choices. I start having these ACP conversations because I knew at the time when I had the skin cancer thing, and I realized it's actually deteriorating. Her mobility is getting worse, and she struggles to climb onto my the bed for me to excise the lesions. And her daughter told me that she's less engaging at home as well. And I printed out the 3 documents. I know that she's the June power of turning, but I printed out the statement choices as well as the health direction, and she started thinking about all these things. Now, 2 days later, in fact, a day and a half later, she was admitted to hospital for hematemesis, and her hemoglobin was only 68. And I didn't know what happened, so I called her because I thought, was it the complication from my surgery? I was worried, and she told me, well, didn't know why she vomited, a day after, and she vomited blood. She was panicking. She took her to the hospital, and was very confronting because at the hospital she had to have a urgent ligations because there was a lot of blood coming out from the stomach, and there was a gastric ulcers. It was so confronting because the anesthetist asked her, would you like us to resuscitate her if she had a heart attack on the operating table? And fortunately, I had this discussion a day and a half earlier on, and she thought about it, and she had this discussion on the dinner table with her mother. So what I'm trying to say is that never too late. We have these discussions and trying to do it when the opportunity arises. And she told me it was very confronting. She was panicking, but fortunately she thought about it and she made the right choice. And also fortunately she recovered. And I saw her, just 2 weeks after, and then she's fine. Now I just want to uh, discuss some of the barriers about goals of care discussions. And one of the things that we thought that was that patients and the family were not ready to talk about goals of care. And therefore, we shouldn't start the conversations until some triggering event. In fact, you'll be surprised that most of the patients and caregivers are willing to talk about end of life and goals of care. And they're often willing to initiate the discussions. And to your surprise, and to my surprise as well, I did a lot of goals of care discussions, and I try to have the opportunity, but you have to be very careful, very gentle to start these conversations. The other myth about goals of care discussions is that it could lead to loss of hope. I think this is more of a conversations rather than about loss of hope. It's not about the end. It's about preparations to the end. It's empathetic discussions about the prognosis and we use this end of line care and goals of care to build trust between us and the clinicians and also the caregivers without affecting their hope. The other thing about goals of care discussions is that often it's hard for the clinicians because and they worry about when the patients or the caregiver ask, can you tell us the prognosis of the condition? So this is difficult, particularly in situations such as cardiac failure. But there are several tools out there that can help us to provide an estimates of the life expectancy. For example, Seattle heart failure model. I've also done some work on the prognosis based on the patient's Konosky score. So you can use it as a guideline, but also bear in mind that we don't have the magic ball here. We don't have a crystal ball. We can't tell, but it's all about preparations and conversation. It's very, very important. And the last barrier is we are too busy. So this is so true, particularly as a clinicians. We have very limited amount of time. We have five patients in front of us waiting to see you. But then again, I always encourage them to come back and try to have the opportunity to have these conversations. Now, how to approach these conversations? One is very important is to recognize the triggers and start early. And the triggers to AD was his deterioration is multiple presentations to the emergency departments. Or the patient I just saw 2 weeks ago was that frailty. Reducing mobility. Use these triggers to start these conversations and try to open up a statement. For example, I like to talk to all my patients about some topics that can be difficult to discuss. That includes talking to people about what is important to them and what they would want their health when they deteriorate. And would you like us to have a chat about this? And if they don't want to engage, you just want to explore why. You want to know why they don't want to engage and try to address those concerns. And often it's not the patients you engage with. For example, the lady I spoke with, I tried to engage with the daughter because I knew the daughter would start these conversations with the mother. And also explore their understanding of the medical situations and asked about the prognosis of the chronic conditions and try to acknowledge the uncertainties. I don't have a crystal ball. I don't know when you're going to die, but it could be a few months so a few weeks to a few months. I don't know, but what we can do is that why don't we just prepare things so that it creates less stress for you and for the family when the situation arises. And also we try to use this opportunity and try to we frame the goals here. So what are we achieving here? So is there anything that you would like to do that would optimize your joy, optimize your happiness, and minimize the symptoms? So these are the things that, and it's very important. And we'll use this opportunity to explore the values and also the fears, the guilt. And I urge, very importantly, to summarize and document discussions on the clinical note and take this opportunity to complete the advanced care planning, upload the ACP, as suggested by Janelle, send the emails or upload to my health record in best practice or whatever engine that you're using. Lastly, I'm going to just to talk about some of the stepwise approach to discuss those goals of care, and some of the GPs or nurses out there know a lot about goals of care, but some of you may not familiar with this approach. And these are very simple acronyms called WEMAP. Number one is reframe. So first of all, it's very important is to assess patients and the carers' perceptions and try to understand their understanding of the current clinical status and the prognosis. Once you have a shared understandings, then you can make a reframing statement. For example, given the progressions of the disease, it seems like it's a good time for us to talk about what to do next. The next is to expect emotion. Watch for the emotional cues and attend the emotional needs. And acknowledging the emotions would help us as a GP or nurses to explore them a little bit further. For example, AD came to me when I, talk about the girls, and she started crying first. And then I asked, what happened? Can you tell me more? And I gave him 20 to 30 seconds of the silence. And you'll be surprised, silence helps a lot, and they start telling you the story. And the next would be to map out the future. That is, well, given what you know about your illness, tell me what's most important to you right now? What worries you most? As you think about the future, are there situations or things that you want to make sure you want to avoid? For example, I do not want to go to the hospital. Yeah, I want to see my children. I want to eat well. These are the things, and try to plan for them. And importantly, to demonstrate that you are on the same page with the patients, and also that the patients and carer has been heard. Then you have to make sure that you show them you align with their values, such as I hear you saying that what's important to you is this. Okay, and then you plan the treatment that matches with their values. For example, they worry about the pain. Then, well, would it be helpful for me to offer the following recommendations? So these are the very simple stepwise to help to start these conversations. The last slide is these are the pitfalls about goals of care. Number one, starting too late because you don't have time to plan. Second, you expect dramatic changes in plan of the care too soon. You have these conversations today, you might expect changes, weeks or months down the track, but you plant the seed, okay? And it's important to understand that you won't be able to complete the discussions in one consult. I have done multiple consult on one single patient who decided to continue with the chemotherapy treatment until 2 weeks before his death. But you keep doing these consultations, but you understand their value is I want to extend my life because I still have young kids. And there was a 40-year-old gentleman who just doesn't want to give up. That's okay. We try to offer the best we can, to pain management, to align our values and align their values with their treatment plan. And sometimes the use of the phrase goals of care in the discussions can be misinterpreted by patients, families, and carer because they worry that stand for not for resuscitations or used in cases there's a conflict in treatment choices. And you have to clarify that because what we're trying to do is to shifting the goals to make, for example, patients more comfortable. Okay. So I'll stop right there because I hit the 30-minute marks, and these are the references. I welcome for any questions. Thank you.
Thanks so much, Raymond. Any questions from the audience? Thank you. I think for me, Raymond, one question I have is when you have a patient that has a chronic disease and they have a long-standing relationship with their treating specialist team, but the conversation is never occurs with the specialist team. And I have read some reports that GPs feel like they can't have these conversations if the specialist or treating team haven't led that. And what's your thoughts on that, or your experience on that?
This is a very, very good question. In fact, I always write letter to the specialists. I told them the situations, and then I will also explain to them. And we had a long discussion about goals of care. In fact, it's not the specialist fault, because they were there to focus on the treatment. For example, in heart failure cases, and you want to titrate the medications to make the patients more comfortable. But then again, it's also you need to let the clinician know that there's a different pathway now we are entering into. And I will explain to the clinicians that, look, I'm going to prescribe some medications because, for example, why do we put patients on the statin if we are on the palliative care pathway? And in fact, sometimes I will engage and call the specialist up. I said, well, would you think that we should increase the furosemide so that he make him more comfortable, or should we, reducing certain medications or changing from furosemide to spectral, things like that. And you'll be surprised. The specialists are far more welcoming, and sometimes you could see some resistance from oncologists, for example. But my experience these days, with my engagement with the oncologists, they actually very happy, and the fact that you are very much on board on making the patients comfortable, and you make them realize the importance of holistic care. And I think it's a two-way education, in my opinion. Yeah.
Yep, great. So you're educating for your patients and you're educating for the treating team as well, like you're the intermediary.
Well, I think the educating on that the needs of the patients, because they would not realize the needs of the patient, it's something else. And as a GP, because we understand their life more, so we are able to provide a little bit more from a holistic point of view. So and that's my thoughts on this. Yeah.
Yep, thank you. Any comments or questions? I can't see any hands up or any questions in the chat. I have another question. Is around when you generate these conversations, I think we all carry our own biases or unconscious biases of what we believe is the right choices or directions for patients, including what we think a good end of life journey looks like. How do you carefully not impose that on your patients and allow them to make decisions or choices that perhaps you don't necessarily agree with or you think isn't the best for them?
Yeah, good question. I mean, go back to the examples I gave earlier on. I've got a 40-year-old gentleman who have terminal, bowel cancers, rectal cancers, and 2 weeks before he died, and he still insists, I really want to continue with the chemotherapy, and came up to me with all these off-label managements. And you will have these discussions, and you will try to understand where it's coming from. He has two young kids. He wants to extend his life. He wants to spend more time with the kids, and he believes that by having these treatments, you'll be able to extend a little bit more time. And you have to trust the patients, and this is what they want, and trying to do for the best of the patients. I understand that perhaps you should there are BMJ studies and showing that by going to palliative care pathway, in fact, their life will be extended. And you can tell them that. But then again, you won't change their mind, because in their mindset, they believe that by engaging with this chemotherapy, off-label therapy, they may be able to extend their life months or even years. So they expect miracles. But at the same time, you have to lay down the fact, and the reality is that, they're not improving, but you have to be very, very gentle and try to not use a word, because you lose the trust if you're imposing something on them. And once you lose the trust, you lose the patience, and you can't help them when they need you. So it's very important to continue with the trust. Um, and I keep telling people that trust versus treatment, which one is more important? Of course, treatment is important, but without trust, you can't treat them. So, because they will never listen to you. So earn the trust first before you engage with them with treatment. So it's very important.
Oh, great answer. Thank you. Great insight. Thank you. One more question from me is, you talked about holding space and allowing for emotion in a busy clinical setting, which we've all come from. And one of the things that I was taught when I was working in the specialist palliative care space, and I'm a nurse, and we're very task focused, and we have our jobs to do, our patients to see. And one of the learnings that I had was the task of holding space to allow for holding space for emotion is also a very valid intervention for our patients. What do you think about that?
Oh, so true. So true. I have so many examples of holding silence, allow them to tell you story. And one of the biggest problem with general practitioner is that we interrupted after 8 seconds into the consultations, and I have to stop myself. I have to allow patients to talk. And this is particular in palliative care space, and spaces in mental health, as you know. It's so important to allow them to tell you the story. If they tell you half-cooked stories, you can only provide half-cooked treatment. So you have to let them to tell you the full story so that you are able to offer what's the best for them. Yeah. But then again, in a busy clinic, you can't. But I think for me, I'm very lucky because all my patients understand that I am late for a reason. So they will forgive me. And they knew that I have to do certain things, and they are very forgiving. So I keep apologizing to all my patients when I'm late. I apologize. I'm so sorry. And I can't promise it won't happen again, but I'm so sorry. Yeah.
Thank you. Thank you, Raymond.
Oh,
So,
got another questions here.
okay,
Yes.
great.
Yeah, so without the pronounce, how do we set the goals of care? Oh, this is very good question. Because I have situations where the family members doesn't want the patient knows because of the anxiety that will causes this. And there are two school of thoughts. One is that, well, you have to inform consent, you have to let the patient know. But on the other hand, that you have to understand the psychosocial aspect of it. This is what I do is, number one, does the patient has capacity? And number two, does the patient has enduring power of attorney? Now, if the patient has enduring power of attorney, and I'm happy to get around the prognosis. I tell you situations, and I've got situations where and the patients, the elderly was very old. It's frail, chronic illnesses, and had skin cancers. And even the daughter doesn't want me to tell her that she has skin cancers when I actually dissect, cut out the skin cancers. I have to say, I'm just trying to cut something to close the wound. I have to tell them, but knowing that, because I knew that if I tell her the skin cancers and she would not allow me to treat her, and she would have this anxiety attack and she won't be able to sleep. But I'll let her know that after I cut the cancers and I show her the result, then I'll let her know. Same goes for the prognosis, and you just have to tell the patients you don't know the prognosis. Yeah, so you don't know. But what you can offer you in those situations is I can offer you the best possibly can so that we can set the best possible goals for you so that align with your values. What would you like to do? No, I told her the story, for example, I told her a story to all my patients. I said, one time when I was driving my car from Canberra to Sydney to visit some friends, and we have 2 young kids, and we left the kids to someone to look after. And then while we're driving the car, I said to my wife, I said, well, what if both of us had a car accident, and then who's going to take the custodies? And then we start, thinking about, well, who are we going to send our kids to? Across on my brother, across on her sister, we cross on everyone except, well, one of our good friends. And the moral of the story is that we don't know what's going to happen next. Same goes for chronic disease and even cancers. And I said to those patients, I said, look, I don't know whether I will leave tomorrow because things could happen. The best way we can do is to plan ahead. So if things happen to you, let's say tomorrow is your last day, what would you like to do? And that helped them to think about things. So not trying to target these, unknown prognosis to the situations, but in general, what would you like to do? Does it answer your question? Cool.
So I think, Chin, thank you for the question. So thank you, living in hope.
Yes, living in
Yeah.
hope. Absolutely.
Yeah. And talking about the noticeable deterioration despite what is causing that or what the prognosis is. Yeah.
Yes, absolutely.
Yeah. Great. Well, thank you everyone for joining. Any comments for Raymond and Janine as we wrap up for this evening? Again, I want to say a big thank you to both Janine and Raymond. As you can tell, we have some really great champions working in general practice in the healthcare setting in ACT regarding advanced care planning and goals of care discussion. And I really hope and trust that some of what they've talked about today really has encouraged you and inspire you to be courageous and have conversations. And we really appreciate your work. Thanks very much, Raymond and Janine. Thanks, everyone, for attending. And don't forget next week, our next session on, which is session 3, which we will talk about primary and specialist palliative care resources and the services available in ACT. We will have 2 GPs, a practice nurse, and a palliative care specialist trainee all join us next week to discuss those. And so some of the practicalities around recognising a palliative patient in primary care. So I have a question here about an RN with CPD points. Nellum, if you can reach out to us, we can talk about that, but absolutely you will get a certificate of attendance for the session tonight and any other sessions. So thank you very much. Have a great evening and hopefully we'll see you next week. Bye-bye.